This will be an outline of what I will be talking about during today's lecture. We'll start with introductions. We'll have a review of prostate anatomy that is pertinent. We'll discuss CT simulation for intact prostate cancer treatment planning. We'll discuss briefly important normal pelvic anatomy structures before really diving into the core of today's session, which is the intricacies and challenges of accurately contouring the prostate for intact prostate cancer IMRT treatment, focusing on areas of specific difficulty contouring the prostate apex, the mid-prostate, and the prostate base and seminal vesicles. And then we'll conclude the evening. I really am so happy that people have already placed questions in the chat, and I encourage you to continue to do so. Ben, hopefully you can interrupt me if there's a question that we should pause and address while I'm talking. But while I have a number of things that I think are important to talk about in relationship to prostate cancer contouring for IMRT, I really want to make sure that I'm meeting you where you are and giving you the information that you would like, and really view this as a conversation. First, I just want to introduce myself. So I am at the Medical College of Wisconsin, which is in Milwaukee, Wisconsin, in the Midwest region of the United States. I snapped a photo as I came into our cancer center this evening to prepare for the lecture, and we received our first measurable snow yesterday evening. So for the next couple of months, I am going to be wishing that I was with you in Southeast Asia in the tropics, because I'll be shoveling snow. So as Ben mentioned, I am a radiation oncologist, and prostate cancer and GU malignancies in general are one area that I specialize in. I also treat lung cancer and esophagus patients. I'm part of our department's inpatient palliative care team called PROMP, and I have a rural clinic in which I practice general radiation oncology. So that's the core of my clinical practice, but my extra clinical interest is really in global health and global health education. This is really the work that inspires me on a daily basis, and is how Ben and I became connected. My primary global radiation oncology partners are Christian Medical College in Vellore, Tamil Nadu, India, and Mulago Hospital in Kampala, Uganda. I also work with the International Cancer Expert Corps, Rios Contra Cancer, and our professional societies. And really the focus of the global health work I do is global health education, facilitating educational exchanges for the students, residents, and faculty that I work with in the United States, as well as inviting people from all over the world to our campus here in Milwaukee. So I'd like to get to know you all a little bit better. And I have two Zoom poll questions that I think Ben will facilitate so that I can better understand the group that I'm with right now.
So I launched the first question. How does prostate cancer most commonly present in your clinic? Does it usually present as low intermediate risk prostate cancer, as non-palpable high-risk prostate cancer, as palpable high-risk prostate cancer with seminal vesicle invasion and extracapsular extension, or as metastatic prostate cancer? And it's good. I see 70 participants so far have filled it out. Now 80. Good. Okay, now we're at 90. We'll give maybe 5 more seconds. So put in your answers if you can. Doesn't have to be exact. 3, 2, 1. Okay, so these are the answers that we have, Dr. Longo.
Yeah, so I'm fascinated. It seems as if in your cancer centers, you are dealing with patients that are presenting with locally advanced and or metastatic prostate cancers most commonly. And I would say it's the flip in my clinical practice, where most of the prostate cancer patients that I see have non-palpable, low, intermediate, or high risk prostate cancer. Let's move on to the next Zoom poll question.
Okay, the next question is, what radiation technique do you most commonly use to treat prostate cancer? The options are 2D radiation, 3D conformal radiotherapy, IMRT, brachytherapy, or I don't frequently treat prostate cancer. So please put in your answers. Okay, we'll give 5 more seconds. 5, 4, 3, 2, 1.
So it looks like the majority of you, more than 80% of the group, use IMRT to treat prostate cancer, with a minority using 3D conformal radiation therapy. So I think we are all doing prostate cancer treatment very similarly, which is really helpful. And I think this talk hopefully will be really relevant to your clinical practice. Thanks, Ben, for facilitating those. Okay. So let's move forward. So, in this era of IMRT, where we have, really focused target doses with rapid fall off, the challenge for us is to make sure that we are covering all of the area that we are concerned about. In the case of prostate cancer, that means making sure we are covering the entire prostate without missing any prostatic tissue. While on the other end of the spectrum, ensuring that we are not over contouring our prostate and including all of the critical surrounding organs at risk in this area, like the bladder, the rectum, the colon, the penile bulb. Where we really want to be is right in the middle, where we are accurately contouring our prostate clinical target volume while not missing any prostate and not, encompassing normal organs that do not need to be included. This has been well studied. There is significant variability in prostate CTV contouring. This graphic that I have posted here comes from a paper published in a German medical physics journal by Mokley et al. And it consists of 11 different radiation oncology centers in Switzerland were all given the same prostate cancer case and asked to contour. Each center is represented by a different color. And as you can see, there is quite a lot of variation when we look at the contours that each center delivered. So there is a lot of interpersonal variability in prostate cancer contouring, and this has been well documented. And it's also difficult. It can be really challenging to contour the prostate. This is a study that was published in 2007 in the Green, or an image from a study published in the Green Journal in 2007, where a 1 millimeter anatomic photo of a prostate was obtained and used as the gold standard for prostate anatomy. And that was superimposed upon a 3 millimeter CT pelvis, and radiation oncologists were asked to contour. And those contours were compared to the, again, anatomic gold standard. And what this study demonstrated is that people over contoured the prostate by about 30%. And let me just see if I can try the annotating here. If you can, are you able to see my mouse, Ben? Maybe you can just confirm. Can you see my mouse?
Yeah, I see your mouse.
Oh, great. So in yellow, we see the CT contours laid or overlaid on the anatomic gold standard. And here we include a significant portion of anterior fascia, which is outside of the prostate. So we over contoured, we contoured too much. But on the other hand, there were areas of the prostate, especially posterior here, where radiation oncologists missed. They didn't sufficiently contour parts of the prostate, especially posterior. So of these contours, only 84% of the prostate was adequately covered on average. So I think this really demonstrates how difficult prostate cancer contouring can be. So this leads me to the next Zoom question. And Ben, if you can facilitate that. What area of the prostate do you find most difficult to contour?
Good, so go ahead and put in your answers. This is very interesting to see as they roll in.
Mhm.
Okay, we'll give you 5 more seconds. The apex, anterior prostate, posterior prostate, or the base, which do you find most difficult to contour? 3, 2, 1.
So it looks like out of the group, the apex seems to afford the greatest challenge for you all, followed by the base and then the posterior prostate. I would have answered all of these at times because there have been cases where I've had difficulty contouring each of these areas, but I do think the apex in particular is a very challenging structure to contour, followed by the base. So I would line up right with you all, although I've had difficulty contouring all of these areas at times. So this is the question that you should look familiar to you all, as it was in your pre-course test. For an intact prostate, how should the final prostate contour appear on sagittal view after contouring the apex with the correct technique?
And so we'll give you a second chance at this question. We didn't reveal the answer the first time, but we'll see what the people's opinions are. So is it A, B, C, or D? And this is an MRI image, the sagittal view. Okay, this one takes a little bit more time to think, so think about it and then try to put in your answer. And remember,
Ben,
this
I'm
is all...
wondering if we can revisit this question later in the talk.
Sure, yeah, definitely.
I know I didn't include that, but that might be
Yeah, we
nice
can
to do.
relaunch the Zoom poll questions. Okay, good. Let's try to get just a few more responses. If you're not sure, it's okay to guess. Better to guess than to not put in anything. Okay, 5, 4, 3. This is gonna be interesting. 2, 1. Okay, ready for the results?
So we'll go forward. So the correct answer is D. So that was the second most popular choice. 27% got that right, but the selections were pretty evenly split. I really would like to revisit this question at the end of our talk today to see, if those percentages change. But, we are going to really spend the majority of our time trying to better understand why answer D is the correct answer. Okay, so let's move forward. So, I'm not going to spend a lot of time reviewing the prostate function and anatomy, but just a brief overview and reminder that the prostate's purpose is to contribute fluid to the semen so that it can survive the acidic environment of the vagina. And, its gross anatomic borders are anteriorly the pubic bone and the retropubic fat and vascular plexus, posteriorly the rectum, more specifically synovial fascia, which we'll discuss further. Superiorly, we end at the bladder neck, and inferiorly at the GU diaphragm. And I always love looking at these anatomic cartoons because the anatomy is pristine. It is perfect. And I think we could all commiserate that when we are contouring these patients, the anatomy is often far from perfect. But these are certainly important references and reminders of key prostate anatomy. And within the prostate itself, there is quite complex anatomy. There are different zones that lie within the prostate that have different functions, but relevant to the work that we do, these zones can impact, the shape and extension of the prostate. I just want to call your attention to the cartoon on your right, which is a sagittal view of the prostate. here where my arrow is, this is a normal sized prostate. Posteriorly lies the peripheral zone. About between 60 and 70% of prostate cancers arise within the peripheral zone. And posterior to the peripheral zone is the rectum. These are the tumors that we can more easily feel on a digital rectal exam. The central zone in blue surrounds the duct that goes from the seminal vesicle to the verumentarum that contributes fluid to the semen. And the transitional zone in pink here kind of surrounds the urethra as it passes from the bladder neck through to the prostatic urethra. And this zone in particular can have a dramatic impact on prostate anatomy and subsequent treatment volumes. And as we move to the cartoon on the right here, again, this is a sagittal view of a prostate. We can see that this transitional zone has ballooned, and that is in the setting of benign prostatic hypertrophy, which is a very common condition in men that leads to benign enlargement of this transitional zone, which can lead to obstructive urinary symptoms. But this is prostate, and this transitional zone can extend into the bladder neck, and as we'll discuss later on in the talk, impacts how you appropriately contour the prostate. I want to call attention to the anterior fibromuscular stroma. This is part of the prostate as well. In smaller prostates and in younger men, this anterior fibromuscular stroma is much more prominent. As men age, prostates become larger due to conditions such as benign prostatic hypertrophy. We can see that this anterior fibromuscular stroma flattens out and effaces and it gets much smaller. So just remember this, keep this graphic in your mind as we go on with today's talk. All right. So, there are different imaging modalities that we use for the prostate. Central here is the ultrasound, which accurately delineates the prostate and can even show us some of the different zonal anatomy, like the peripheral zone, the transitional zone. Almost all prostate biopsies are obtained through transrectal ultrasound. So this is what our colleagues in urology will see as they are doing biopsies to confirm prostate cancer. On the left here, we have an axial slice of a T2 weighted MRI scan, and we can also see that zonal anatomy. So here, posteriorly, we have the peripheral zone. Anterior to that, we have the transitional zone. We are not seeing the central zone in this slice, but here, this dark kind of hypointense area represents the anterior fibromuscular stroma. Beyond that, we are out of the prostate, and this is the fascia, and then the fat plane between that fascia and the pubic bone here. Now, I'll draw your attention all the way over to the right, and there is our CT scan, which we are all using to contour, and we can't see any of the zonal anatomy at all when we look at the CT scan, or not very well, at least in this example here. So I think this is just kind of introducing some of the challenges in delineating our prostate volumes that CT brings on. So this is my next Zoom question. Do you use MR prostate for diagnostic workup or treatment planning? Ben, if you want to launch that, please.
Great. So do you always use MR prostate for workup or for treatment planning? Sometimes, rarely, or never? This is such a good question too. Okay, wow. People responded pretty quickly. Okay, we'll give 5 more seconds. 4, 3, 2, 1. Okay, these are the results.
Yeah, so it looks like almost 90% of the group here is using MR prostate either as part of the diagnostic workup or as part of treatment planning, which is fantastic. Out of full disclosure, I obtain a CT MRI simulation on every prostate cancer patient that is able to have an MRI scan. So it has become a standard part of my practice. But this has evolved over the past, I'd say, 6 or 7 years. When I was in training in the early 2000 aughts, we only obtained CT and rarely obtained MRI scan. But now where I am today, I get an MRI sim with all patients that are able to have MRI scan. That is fantastic that you all are using MRI scan. And, maybe Ben, you'll have to invite me back to do an MRI focused prostate cancer contouring lecture, because that really, it's not touched upon deeply in this evening's talk. Well, I'll show you some MRI images, but it's not the thrust of this talk. It's really a CT based lecture.
Sure. And actually on this slide, actually, one thing I want to call out, because I actually made this mistake. Getting the MRI, I thought, oh, great, I can see the prostate perfectly. Here it is, here's the prostate. And didn't realize that the peripheral zone should be included, but it just looks a very different color, and you can mistake it for fat. So there are some nuances with our contouring. So yeah, that would be great.
I think a necessary session for the future for this group. But again, the thrust of tonight's conversation will be CT-based planning. And there are pitfalls of MRI, and we can maybe even look at some of those cases here. So, I think, before we can get our hands on or start to contour, the first step is to perform a CT sim. And this, having a good CT sim scan, which, enables optimal positioning for our target and to enable us to avoid our critical organs at risk, it must be in a position that is reproducible for the 20 or 28 or 42 treatments that the patient will undergo. And the patient has to be able to tolerate being in that position. So, this is a critical piece before we can even start to contour, that we have a good CT sim. Typically, and I'm sure you're all well versed, and I'd love to kind of learn what your practices are, but we simulate the patients with their bladders comfortably full. And I want to emphasize comfortably full. In my experience, I have gentlemen that are so concerned about having their bladder full that they drink so much water that their bladder reaches their diaphragm or their lungs for the day of the sim, but it's a bladder filling that they cannot reproduce subsequently on a daily basis for their 20 or 28 treatments. So I really want to emphasize comfortably full. Now, there are guidelines that are given. The Estro has guidelines for recommending that patients drink 500 milliliters of water 30 minutes prior to simulation. I think, we tell patients to drink 24 ounces, which is a pretty similar amount in our measuring system. But bladder filling is highly variable. It's impacted by patients' baseline hydration, their activity level, the amount of salt that they have consumed. So it's really a combination of amount and timing of bladder filling and, the patient's actual feel. And you want to sim them with a bladder that you think you are likely to be able to reproduce on a daily basis. Similarly, with rectal emptying, the Estro guidelines recommend that consideration of a laxative prior to CT simulation to empty out the bladder or empty out the rectum. And again, we want a relatively empty rectum to avoid the overlapping the high dose of radiation with the anterior rectal wall to limit rectal toxicity. My approach to rectal emptying is that I really encourage my patients to have a bowel movement prior to simulation and prior to treatment, but I don't want them to do things that are so different from their daily routine. I urge them to avoid big gas causing foods because that can be an easy way to cause distension. But I don't like the idea of giving somebody an enema or having them take a lot of laxatives every day for radiation treatment, especially as one of the side effects of radiation therapy to the prostate is diarrhea. And one thing that I do if a rectum looks too enlarged during my CT sim, or a bladder doesn't look sufficiently full, is I go back and I pull up their diagnostic imaging to see, hey, is this the way this gentleman's rectum usually is, or is this just today it's abnormally full or abnormally gassy, or the bladder isn't empty? So using those diagnostic imaging studies to help learn if this is consistent or an aberrancy for the patient. We of course immobilize the patient, and I think you are all well versed in this, so we can just breeze through that. The use of contrast is interesting. I use oral contrast in my practice to better outline the small bowel. I do not use IV contrast in the setting of prostate cancer. I think the cost and the potential nephrotoxicity or allergic reaction outweighs the benefit of using IV contrast. And in the setting of doing MRI simulations, I no longer use a urethrogram to better identify the apex of the prostate, although that is certainly a very reasonable procedure to do. I think it's important to talk about CT slice thickness. It's recommended that for prostate cancer treatment planning that CT slices are less than 3 millimeters. It's our standard at the Medical College of Wisconsin to use 2 millimeter CT slices. For those of you that's difficult to do, one suggestion is to use thin slices from the top of the femoral heads to the bottom of the ischial tuberosities, the area where the prostate is, and then larger 5 millimeter slices over a larger area. And again, when we're thinking about how much to include in our CT scan, typically I start at the top of the iliac crest when I'm just treating the prostates, and I want to make sure I get through the entire genitals. As we'll discuss shortly here, men's anatomy can be very different. We think of the penis and the scrotum as being quite inferior to the area that we're treating in the prostate, but that is not the case for all men. And some men's genitals are much closer to the prostate than you'd anticipate, and that could be easily overlooked, leading to higher than necessary doses to the penis and the testes. So let's make sure to encompass all of the genitals.
Dr. Longo, we have one question about CT
Yeah.
simulation. It's from WQ, who asks, what do you think about low residue diet on rectal volume?
Oh, that's a really great question. So I am a big advocate of making diet and behavioral modifications for men that have radiation-related side effects. What do I mean by that? So for gentlemen that are having bowel irregularity, loose stools, diarrhea, rather than immediately putting them on medications to slow their bowels down, my first step is to transition them to a low residue, low fiber diet. And I feel like there's even a step in between going from fiber to a low residue diet, and that's having men avoid insoluble fiber. Those are the foods that have skins and seeds, so fruits and vegetables with skins or seeds. I think of the cruciferous vegetables like broccoli, cabbage, cauliflower, Brussels sprouts. I think of onions as foods that cause a lot of gas and irregularity. So I'll transition patients first from a regular diet to a diet with soluble fiber. Those are the gentle fibers like whole wheat breads or noodles, oatmeal, peeled apples, carrots. If that doesn't slow their bowel irregularity or gas down, then I do put them on a low fiber diet. I don't do that until they have symptoms, typically. Okay. So moving forward, we're not going to spend a lot of time discussing or contouring normal pelvic anatomy. I did send this RTOG consensus guidelines out as pre-reading, and you have that for your review. But I do want to focus on two normal organs approximate to the prostate that I think are really critical for contouring the prostate, in fact. So one is the rectum. And rectal toxicity is in addition to bladder toxicity are the two organs that I think we're most concerned about in the setting of prostate cancer treatment toxicities. And I thought I'm going to stop sharing and I'm going to go to MIM and I'm going to do a little bit of rectal contouring as we kind of talk about how to effectively contour the rectum. So let me just share my MIM screen here. All right, and I'm going to turn these off so I'm not cheating. Are you able to see MIM, everybody?
It
Okay.
looks good.
So and my mouse is in reverse, so I'm a little bit confused here. But I'm going to just make a new rectum new. And so by definition, the inferior border of the rectum is at the inferiormost level of the ischial tuberosity, whether it's the left or the right. So here we see just a remnant of the left ischial tuberosity. And for those anatomy sticklers, this isn't the rectum at all. This is the anus. From the anal verge, it's typically between 3 and 4 centimeters to the inferiormost aspect of the rectum. But by definition, when we contour the rectum for prostate cancer and most pelvic malignancies, we include the anus. And again, the inferior border is kind of at these levels of the ischial tuberosity. Now, as you can see, as we go kind of superiorly, I'm not contouring every slice, the anterior border of the rectum gets a little bit hazy. And, as we'll kind of come, here we're getting actually kind of near the prostate, the apex of the prostate. It can be hard to see what is rectum versus what is prostate. And that's, I think, one of the challenges that we face when we're using CT for contouring. That is where another area where MRI, either fusing a diagnostic MRI scan or doing an MR simulation, can really much more clearly demonstrate the muscular wall of the rectum. Now, where do we stop the rectum? Well, by definition, in R2G, they stop when we see the rectum kind of moving anteriorly. So let's see, we see it kind of starting to move anteriorly into the sigmoid colon. So I'd say by the last, and it's the kind of last slice where the rectum is kind of round in shape. So let's see what we look like about here. And I think it's also important to look at things in the sagittal perspective. So we're kind of at the level of the base of the prostate or kind of by the seminal vesicles here. So that's kind of the RTOG definition of where the rectum ends. Now, I will tell you in my clinical practice, and I actually kind of follow the rectum until it clearly moves anterior. So I would call this little area of tissue rectum. I call this rectum until it clearly moves forward into the sigmoid right here, because I would call this sigmoid. And, I think the conservative thing to do is to use the RTOG definition, which would really stop the rectum right here. Recent clinical trials in the Intact setting, like R2G 0924, use kind of this definition of where you clearly see anterior movement into the sigmoid colon. And that's what I often use in my clinical practice. But again, the more conservative thing to do would be to cut the rectum off at the R2G definition. Why is that more conservative? Well, our constraints for sigmoid colon are much tighter or more restrictive than they are for rectum. Okay. And Ben, do we share the slides with the group afterward?
Yeah.
Do you do that? Okay, excellent. Because I've included these slides just for your reference going forward. So we see this is clearly in the sagittal plane that
Can you share the screen of your slides?
Oh, I'm sorry. Let me do that. Yep, here I'm just sharing with myself. Hold on here. Sorry.
No worries.
This is going to be the challenge, everybody. We'll try to do it as smoothly as we can, but here we go. So again, I've included these for your reference, and you can go through them. So like I said, I tend to use this RTOG 0924 definition, where we begin at the rectosigmoid flexure as that moves superiorly and anteriorly. So let's now look at the penile bulb, because that's going to help us with our prostate contouring. So just a reminder, the penile bulb is the portion of the bulbous spongiosum inferior to and posterior to the GU diaphragm. It's typically a circular or more often a teardrop-like shape. So I'm going to stop my share here and pull up MIM. And I'm going to go to another patient here. Bear with me, everybody. Okay, so I'm going to, so typically the one, again, an advantage of MRI scan is that the penile bulb tends to be quite hyper enhancing. And you know what's been interesting as I prepared for this talk, I recognized areas where maybe I did not contour quite as accurately as I would have wanted to. So again, this is the corpora cavernosum here of the penis. I'd say it's really helpful as we're contouring the penile bulb to use all planes, both the sagittal and the coronal plane. And I'm just going to make a new contour, new bulb. Let's see, it'll be interesting to see how similar. So again, kind of circular nature. Now this should be posterior to the urethra. Without a urethrogram or an MRI scan, it's really hard to see the urethra. But that can be one common contouring mistake, is that we contour the penile bulb too anteriorly. Now it's interesting, the correlation between penile bulb dose and erectile dysfunction is not well characterized, you know, and some people think that it's really just a surrogate for the vasculature and the nerves that are critical to the obtaining an erections. I might call the superior most border here. And, you know, it's not like here we can see in the coronal plane, why is there this triangle that's jetting out there? I don't know. I should look and check that out. Maybe it's, yeah, maybe I'm a little too lateral and I can see there's a little bit of muscle that's there, so I can modify my contour. And that's what I'll tell you. I am constantly modifying. I put something down on the page and then I have to go back and think about it again. Again, I see irregularities both on the right and left lateral aspects of the penile bulb. Just for fun, let's see what I did when I actually contoured this a little bit of time. Oh, wow. So I contoured much more anteriorly and much more superiorly. I don't know.
Yeah, and then this one is tricky, but I do find that the penile bulb and the prostate contours kind of help one another.
Yes.
Because I can see, okay, how low do I think the prostate is going? How high do I think the penile bulb is going? And what's the space I end up seeing in between them? And it can. Mhm.
Go ahead.
Oh, go ahead, Mac.
No, I was just going to say, I think that's really, really critical. Is one way that we can anatomically locate the apex of the prostate is using the penile bulb as a surrogate. And typically the penile bulb is, you know, 1 to 1.5 centimeters inferior to the apex of the prostate. And that actually walks us right into kind of the next part of this talk, is focusing on some of the common errors and challenges in contouring the prostate apex. And, you know, I think my contouring of the penile bulb, you know, a minute ago illustrates just how difficult prostate cancer contouring can be. We talked about how there's variability between different people contouring the prostate, but there can be intravariability. The way you contour a prostate today might be different slightly than the way that you contour it next week. So I think, you know, not that that's a good thing, but it's not necessarily a bad thing. I think it just kind of, it's important to recognize that there is that inter and intra variability. You know, we're human beings. So let's turn our attention to the prostate apex. So this is kind of the bottom or inferiormost aspect of the prostate. It's pyramidal in shape. And again, one anatomic marker is that it's about 1 to 1.5 centimeters superior to the penile bulb. And that's why I wanted to do a little bit of penile bulb contouring. We're gonna try to do some apical contouring in them. And again, I'm gonna challenge myself to just not cheat, and we're gonna contour. Now, you know, there are a lot of things that are, oh, is there a question, Ben?
Yeah, yes. Yeah. Maybe right before we jump into the apex, a question about the penile bulb. Sure. On the axial view, should it appear teardrop in shape, or should it look round in shape?
You know, in my experience, on the axial view, it's more round in shape. And it's really on that coronal view that you can better see that teardrop shape. But, you know, again, human anatomy is highly variable. And you really want to contour what you think is penile bulb rather than totally focus on the shape appearing perfect. We know the atlases that we all refer to are choosing the best anatomy, but in reality, human pelvic anatomy is highly variable. So again, axial, it typically is round or a little bit oblong, but when you look at it in the coronal plane, that's where it's more of a teardrop shape. Okay, so let's move to some of the challenges and common mistakes in prostate apex contouring. Okay, so it can be really difficult on CT to separate between the membranous urethra and the prostate. My mouse is running backwards here, so it's counterintuitive to where I need to go. But you see here, there's not much of a difference between this tissue. Why couldn't that be prostate? It looks pretty similar to the way prostate appears up here. They're pretty iso intense, but clearly this, we know just from kind of anatomic position, it's very unlikely that the prostate is this far inferiorly. But when we look at it on CT, there's not a lot to kind of guide us as to what the distinction between the genitourinary diaphragm and the prostate is. So that's one challenge. Another challenge is that there can be prostate tissue that is interspersed within the muscular tissue just inferior to the prostate. And that's where I think MRI is really superior as we are delineating the apex. You'll see some of my contours as I get down to the apex when I'm using MRI scan will look like, they'll look like kind of like butterflies, because there's a little remnant of peripheral zone that I'm trying to capture. I'm trying to spare the urethra, because that prostate sometimes extends more inferiorly. Again, you don't have the luxury of seeing that because I don't have my MRI fused right next to this. But that's another challenge, is that there can be actual prosthetic tissue within that muscular tissue. And, when we are kind of unclear on the distinction or delineation between the genitourinary diaphragm, the muscle, and the prostate, what can often happen is we get this pedestal. I'm just, again, contouring very roughly here, but we see that, you see that now we're kind of getting more into prostate here. Okay, much more clearly, we're in the prostate, and I'm doing this roughly for you all. So here, I think we can kind of all feel pretty comfortable. This is prostate, but we can see, just looking in the sagittal plane, I'm not going to contour all the way up. We see the way that the tissue appears is all very similar, but we see this kind of pedestal-like formation that's down here. I've way over contoured the apex of my prostate, and I've gone down through the genitourinary diaphragm into the membranous urethra. So that's far more inferior than I need to go for the prostate. And why is that a problem? Well, that's urethra that you're now increasing the risk for urethral stricture down the road, because we're exposing it to a high dose of radiation therapy, and there's not cancerous tissue there we're trying to treat. Another kind of challenge, sorry, as I try to operate this mouse, is the posterior border of the prostate in this area. We kind of sometimes we use the anterior rectal wall as a posterior border, but as we go inferiorly, if we go all the way to the rectal wall, we're going through a lot of tissue that is outside of the prostate, and then it doesn't need to be treated there. So there is anatomic space between the inferior aspect of the apex and the prostate. So typically we don't want to see a kind of convex posterior aspect of our prostate. It should really be kind of concave in this area, and there should be some space in between the anterior rectal wall as we go inferiorly and the prostate. So this is just a prime example right here. I've just contoured way posteriorly, and we can see it beaking out on our sagittal planes there. So if I were to modify this, and this might be actually kind of one of the inferior aspects of the prostate. Think about it. Okay, so I'm pointing out some
Mhm.
mistakes, and I'm drawing the mistakes, but what are some clues to actually contour appropriately? The other thing is we can use bony anatomy as a landmark, but sometimes that can get us into trouble. And I just want to show you some examples of that. So this is an example of a low riding prostate. Just turn this off. So we can see that the prostate, and this is going to be most prominent in the sagittal plane. You can see the prostate is kind of is below the pubic bone. And if we were solely kind of using the inferior aspect of the pubic bone as our mark for the end of the prostate, we would under contour or miss part of the prostate. On the other hand, we can see high riding prostates. I just want to show you this right here, where the most inferior aspect of the prostate is actually superior to the inferior aspect of the pubic symphysis. And I want to show you, let me show you that real quick. So again, we're kind of above the most inferior aspect of the pubic bone. But let me just show you a more extreme demonstration of this difference in anatomy based on the high riding or a low riding prostate. And we're going to go here. So here you can see on the left here in figure A, the apex of the prostate is quite low, whereas in figure B here on the right, the apex of the prostate is kind of almost at the, I'd say, the middle of the pubic bone there. So that could lead to over contouring in this case, if we just relied on bony anatomy, and under contouring on the left here with the low riding prostate. Okay.
Mhm.
So
Mhm.
let's go through just, this is listed in one of the resources that I sent to you all, but I want to actually contour with you. So you have this in the paper and you'll have it in the slides, but let's go and look at a contour of the GU diaphragm here. So we're going to go to this contour, and we're going to call this prostate apex. Okay. And this McLaughlin kind of offers I think, a really good stepwise way to help us to identify the apex of the prostate. So we're going to use our penile bulb, and this most superior aspect is kind of as our starting point. So we have our superior aspect of the penile bulb there. And then we're looking to see a loss of fat plane. So here you see this dark fat there. And then we see a little remnant of fat. So here we're kind of starting to see that fat plane obliterated. And that's really the start of the GU diaphragm. And as we go superiorly, we're going to start to see the circular structures of the urethra. And this clearly is the urethra as it's kind of passing through the GU diaphragm. And now I think the kind of elusive figure that's hard to see, but I think we can actually see in this case, is the levator ani muscles come in and they form almost an hourglass shape. And that really kind of delineates, and again, you kind of almost have to squint to make yourself imagine, but I think you can kind of see it here, that hourglass shape, that delineates the most superior aspect of the GU diaphragm. So this is not prostate, but we are getting close to prostate. And I would say that right here is maybe our first slice, our apex of the prostate. And then as we go kind of, again, this is going to be rough, we're more clearly seeing the prostate come in here. So, so, as a challenge to myself, again, let's just turn on the prostate contour that I contoured. Oh, okay. So there are subtle differences there, but now keep in mind, I used my MRI scan, but the level of where the apex was using that kind of method of starting with the penile bulb, seeing that loss of fat plane to kind of demarcate the start of the GU diaphragm, looking for the urethra here. So this is not prostate apex, this is urethra coming through, and then trying to find that hourglass shape, which I think we can kind of see here and here. That helped me to delineate the border of the apex. Now, I'll tell you, only about 50% of CTs will clearly demonstrate that hourglass shape, which is the most superior aspect of the GU diaphragm and a good marker. But, I think that's kind of a good method on CT
Mhm.
to help.
Yeah. Can we go down just to just kind of highlight the hourglass shape? I can try
Yeah,
to
and let me
draw it with the
delete some of
annotate.
these contours. I'm gonna take this off. Oh, shoot.
Okay.
So
So
here we're getting into the
mhm,
urethra right here.
mhm.
Here we can kind of see right
So
here.
we're looking for something that's kind of like this,
Yep, exactly.
and we can describe this line as either concave or convex, I I think. And the hourglass shape is when it starts to not look like this and it starts to look more like this. So
When you see the convex shape more
mhm,
inferiorly, that's where we're kind of,
mhm,
it's the urethra passing through that muscular diaphragm, that U diaphragm. You see that circular there.
mhm,
So
right.
again, it's a challenging, a subtle finding. MRI scan, one of its primary purposes is to really better delineate the apex. But I think this is, a very reasonable way to help you with your apical contouring. The other thing I want to call your attention to is using your other planes. I think sometimes what's not as clear in the axial is much more clear when we're in the, sagittal and coronal planes. Okay. Now, I want to transition to contouring the mid prostate and kind of some pitfalls that we see in contouring the mid prostate. One is the delineation or distinction between the anterior fibromuscular stroma, which is prostate, and the anterior fascia, which is tissue that is extraprostatic or outside of the prostate. So that can be really difficult. And as men age and their prostate gets bigger, that anterior fibromuscular stroma is often obliterated. So I'm just going to draw, just kind of show you where the anterior fascia is, which is not prostate. And because of that, does not need to be contoured. So we can kind of actually see it here. It moves anteriorly and laterally. And this is fascia. It also houses the dorsal veins, which are vascular structures that we really want to spare because they help contribute to erectile function. So that's not prostate. That's the anterior fascia. But as we get to here, gosh, right in this area, how do you distinguish between prostate and anterior fascia? It's really difficult. So let's make a prostate contour. And what I would say is we see a little bit of a line here that I think represents the capsule of the prostate. And I know that this is where the anterior fascia would typically be. And some people might say, well, why do you worry so much about, if you're not sure if this is prostate or if it's anterior fascia, why don't you just include it? Well, the more we include anteriorly, that means more dose to the pubic bone and importantly, more dose to the bladder. So that's why it's, we want to be as accurate as we can be with contouring this area of the prostate. So anteriorly, it's really difficult, but important to try to delineate between prostate and fascia. Now, one technique to try to do that, to try to make that distinction, is you can window and level. Sometimes with different CT windows and levels, you can see things better. I know my residents taught me that kind of looking in the liver windows can actually help. And you can kind of see there, let's turn all this off. You kind of see the outline is a little bit better as we're in this window. So that's one trick to try to better delineate that anterior border. And what I would say is that, let's just get back to the soft tissue window that I like to use normally. There we go. When in doubt in this area, if you can't clearly see separation between the anterior fascia and the anterior fibromuscular stroma or anterior aspect of the prostate, you are better off to include that. So, we know that this black here is fat. Looks like that's obviously a vessel. You can track it. So we know that kind of tissue, even though it's the same color or it enhances similarly to the prostate, it doesn't need to be included. So those are some of the challenges of the anterior aspect of the mid-prostate. What about the posterior aspect of the prostate? That can be another area that can be difficult. And this is where kind of understanding that basic anatomy is kind of helpful, and knowing that there is a plane that's in between there is a plane that is in between the rectum and the prostate called Denovius fascia, and that actually is a natural barrier to prostate cancer progression and involvement of the rectum. But we see here that if you just relied on the anterior rectal wall as your posterior border in the mid prostate, then you'd be over contouring and subsequently exposing the rectum to more radiation, which is unnecessary. But here we clearly see that plane in between the rectum. Thanks, Ben. That's good to highlight that, and the prostate. So, again, in the mid prostate, this actually can be, it's actually one of probably the easier ways or easier parts of the prostate, because it's, the prostate's big, it's clear, but it's not without its complications. One technique to contour is to start where you can clearly see the prostate. So rather than starting at the apex or starting at the base, which is where we're headed to next, we actually start with the area where we can see most clearly. And so I'm going to stop sharing MIM briefly here, and I'm going to go back to my PowerPoint. Sorry for the whiplash, you all, and just know all of these slides are here for you to review. And that's kind of, again, pointing out Denovius fascia there. So this brings us to kind of the base and the final area of the prostate that we're really going to devote time to, and that brings us to another Zoom question. So Ben, if you can get the poll running for the Zoom question, that'd be great.
Great. So on which sagittal slice is the prostate base most accurately contoured? Which looks correct? A, B, C, or D? Okay, good. Take some time to put in your responses. Okay, we'll give maybe 5 more seconds. If you're not sure, it's okay to make an educated guess. 3, 2, 1. Okay, and here are the group results.
Great. And B is the winner, everybody. So this, encompasses the base appropriately. And one thing I want to call attention to is that there's this kind of reference to the prostate should be globoid in shape. So kind of this oval structure. And I think it's best seen in the sagittal plane. So generally you want this shape of the prostate. Now, again, you got to contour to each individual man's anatomy, but this is the general shape that you want for the prostate. Well, why were the other choices wrong? Well, for choice A, we can see these beak-like projections. And if you were to kind of scrutinize this a little more in a little greater here, you would see that this area where there's that beak-like projection anteriorly is actually anterior fascia. So it's outside of the prostate. And, by covering that, then we're in turn exposing more bladder to radiation therapy. Similarly, posteriorly, we see a projection there into the seminal vesicles. So looking out for these beaks where they kind of shoot out and come back in, especially in the sagittal plane, should be something that you should pay attention to. Now, choice C was wrong because we were missing a whole lot of the prostate. Again, a lot of men with prostate cancer, they're older men in their 60s and 70s and 80s, and they have these large hypertrophied prostates. They have benign prostatic hypertrophy with large transitional zones. They have median lobes that extend into the prostate. So by not contouring that superiormost aspect of the prostate, you're missing a lot of prostate. Finally, as we're contouring the base, one of the challenges is, what's the difference between the seminal vesicles and the prostate itself? And choice D is wrong, because included within the prostate volume is the entire seminal vesicle, superior and posteriorly. I just want to show you a example of just some of the variations in anatomy, especially with large prostates, that I see in my practice. And they are fraught with challenges. So just, you can see here, as we go superiorly, we see how large this prostate is. Let's just see can I get a sense of the diameter? Oh gosh, I'm not going to do that. I have a new mouse here and I'm not so adept with it yet, but so you can just see how this prostate it's enormous, and it's extending into the bladder. It has effaced the bladder neck. So we can't see the bladder neck. It's actually really compressing the seminal vesicles there too. And it extends a good bit up into the bladder. So that's just, I think this gentleman's bladder was 150, or prostate rather, was 150 grams. So just a really large prostate there. Well,
I want to highlight on the sagittal view here, even though this is a giant prostate, you see it still has this pretty round shape. And what we see sometimes more when people are trying to contour the apex, sometimes people are falling prey, and when they get to the apex, they keep going and they end up with something that looks more like this. And that is a common error.
Really excellent point there, Gun.
Right.
Also, just want to call attention to the fact on the sagittal, you can see that this gentleman's penis is actually kind of in parallel with the apex, and that's one where you would want to pay attention to that. If his penis was, pushed anterior and superiorly, you could be, inadvertently exposing it to entrance and exit dose there. So again, just another, reason to pay attention to what you are simulating. I am gonna now do some base, kind of highlight some of the common mistakes in contouring the prostate base here. So with this patient here, and I think one thing that can be quite difficult as we go superiorly is we can see this kind of, we see the prostate here, we can see this kind of merging with we see bladder here anteriorly. Where is the clear demarcation between what's prostate and what's bladder? This area can be very, very difficult and can lead to either over contouring of the bladder neck, so just see how you see that looks pretty similar to down here, or it can be under contouring of prostate. We say, oh, well, there's bladder. This can't be prostate, even though it is prostate. And why are there the variations? Well, again, we talked a lot about the hypertrophy of the transitional zone. We also see differences in the anterior fascia as it kind of connects superiorly to the bladder there. And also the anterior fibromuscular stroma can vary, which can make things difficult. We want to be cognizant not to over contour anteriorly. So let me just show you a mistake that I often see that we kind of had on our test question is people will say, oh, well, that's prostate. Oh, that's, let's see. And we're kind of forming that beak out there into tissue that is beyond the prostate. So we're actually contouring the bladder muscular wall as well as the bladder itself. So that's kind of an area where we can over contour. But on the other hand, kind of come back here, we could say, oh, we could potentially avoid this, which if we look at our imaging, this is actually still prostate. It's kind of extending into the bladder. And if we didn't pay careful attention to that, we could be undercovering prostate tissue that extends into the bladder. So that kind of effacement of the bladder neck is a real challenge as we're trying to delineate our volumes superiorly and can lead to under contouring.
We have an interesting question. This is from Dr. Gregorius Prajogi. Are there any tips on contouring the base in post-TURP patients? It seems like in Indonesia and in Myanmar, TURP is quite common. And so a lot of the patients are being treated in this setting.
Yeah, I think in my clinical practice, I have not, I've seen a handful of gentlemen that have had prior TURPs that I am treating for prostate cancer. So I don't have a vast body of experience with that. And I really don't know what's reported in the literature. I think that's where, looking at your diagnostic imaging, whether it's diagnostic CT scans or MRI scans, also if it's been a more recent TURP, really connecting with your urologist who performed it to, potentially even go over your volumes, I think is one thing to do. We all know that, prior TURPs increase the risk for urethral strictures in patients who undergo intact radiation therapy. So something that you want to be really, really mindful of. So as we're talking about, kind of appropriately contouring the base, the other structure that we pay attention to are the seminal vesicles. And for the seminal vesicles, so we can kind of clearly see the seminal vesicles here. I'm going to superiorly to and posteriorly to the prostate themselves. But again, the prostate anatomy impacts the positioning of the prostate, or impacts the positioning of the seminal vesicles. In gentlemen that have a smaller prostate and younger gentlemen, the seminal vesicles actually are embedded within the prostate itself, or the inferiormost aspect of the seminal vesicles are embedded within the prostate themselves. Whereas in older men that have larger prostates, that hypertrophy of the transitional zone almost pushes the seminal vesicles out of the prostate. So they're really kind of beyond that. So, and I'm using my sagittal in addition, and I'm just seeing that things don't look as much as I'd like them to. So I'm wondering why that is. So I'm kind of just going back and forth. And where I think this prostate seminal vesicle interface, especially in older men, can be really challenging. Where does this seminal vesicle start, or where does the prostate stop? And my approach to that is, if I'm unclear about if tissue is seminal vesicle or if it's prostate, I err on the side of treating it as prostate, because I want to make sure it gets a reasonable dose of radiation therapy. Let me just go back to my PowerPoint slides just to kind of wrap things up about the seminal vesicles here. And again, you will have access to all of these slides, so you can kind of go through. It's my kind of first attempt really trying to live contour, so it's a new experience for me. But this is just, again, some pros on the seminal vesicles. Again, we talked about how smaller prostates, they're actually embedded within the prostate, whereas in larger prostates, the seminal vesicles are pushed really outside of the prostate. And we can see this in these sagittal MRI scans. On top is a smaller prostate, where we see that seminal vesicle really embedded in between the peripheral zone and the transitional zone. Whereas this, we clearly see a large prostate with a large median lobe extending into the bladder. And we see that the seminal vesicles are really beyond the prostate itself because of that enlarged transitional zone. And this is another kind of pearl for trying to make sure you know where the seminal vesicles are in a normal sized prostate. Is usually the seminal vesicles start when you're at the base, the kind of superiormost aspect of the prostate, and then move posteriorly and superiorly. And I also just want to call attention to a resource that I know other lecturers have referred you to as eContour, which has excellent cases across all disease sites and demonstrates not only kind of target volumes, but also normal anatomy. And it's a resource that I personally use, with frequency. So kind of just general strategies for contouring the base of the prostate. As we were trying to do while I was in the MIM contouring, I don't just rely on the axial planes. I really look at the sagittal and coronal views to make sure I'm outlining things correctly. And then this is one tip is, kind of trying to avoid those projections anteriorly and posteriorly as you're moving superiorly within the prostate. Those should be red flags to kind of scrutinize those areas a little bit more. So we're kind of drawing to a close of our evening, and I just want to share some of my kind of lessons that I've learned over time. Is that prostate anatomy, for such a small organ, gosh, can be difficult at times, and there's variation from patient to patient. Even in the limited number of patients that I shared with you that are all my patients that I've treated within the past couple of weeks, there's a lot of variability in the way their prostates appear and subsequently in the way I contour these patients. One thing that we didn't kind of talk about is just kind of how I go about contouring a case. And the first thing that I do when I sit down to contour is I pull up the patient's pathology. Why is that impactful? Well, if there's uncertainty on the imaging, if I have a CT scan, I'm just really not clear on the base or the apex, but I know that, for example, in this gentleman's case, he has left base disease. Well, maybe I'm going to be a little more generous on that left lateral side, and rather than skimp, I'm going to extend my contours a little bit more there. That holds true for wherever there's disease within the prostate. I want to make sure that I'm comfortable with my coverage. So I always review the pathology. Concurrently, I also pull up diagnostic imaging. So this is an axial slice of an MRI scan for a prostate, and we can see that this is a transitional zone PIRADS 5 lesion. So that helps me, as I'm contouring, making sure my contours are sufficiently generous there. But it also just demonstrates, how beautiful the MR prostate anatomy is. So I always utilize and review my diagnostic imaging. Another thing that I've learned is that sometimes I have to take a step back when I'm contouring. If I have a really difficult case, if I feel challenged by the anatomy or things are not clear, sometimes just taking a pause, and coming back to a case with fresh eyes is really helpful. And then I never hesitate to ask people for help. I often am on the phone with our T and MR body radiologists, asking them to review anatomy, especially to ensure that I have the apical border of my prostate correct. I know that takes time, and I'm sure most of you are in very high volume practices, but sometimes that extra minute or two is worth it to be sure that you are adequately contouring your prostate. So in conclusion, understanding prostate anatomy is critically important. The first place to set yourself up for successful contouring is making sure that you have an excellent setup in your CT simulator. I think you all really identified the areas that we all collectively struggle with in prostate contouring: the apex, the anterior and posterior mid-prostate, and the base. And hopefully, I've equipped you with some strategies for thinking about contouring these areas. And again, we did that kind of on the fly in MIM, looking at real life cases, but there are reference slides embedded within this that you can go back and refer to, as well as the references that I sent out ahead of time.